Next we have Dr. T.S. Subha, early initiation of RAS in MAS career.
Good afternoon. Thank you for this opportunity to WALS and to Dr. A.K. Mishra sir. I think the previous talk previous discussion set up my talk very well. It is perfectly timed. So I'm here to talk about why an early initiation of robotic assisted surgery is the need of the hour. So robotic assistants are not new. As Sailesh sir had mentioned, robotic surgery is the present and not the future. There have been robotic assistants since 1985. So we have many systems currently online with multiple device manufacturing companies coming into the foray. Of course, I'm not going into the details. So why is early adoption essential? So me as a resident, when I started my surgical journey, I was taught open surgery and laparoscopic surgery parallelly. There was no levels of competence which were required because that was the need of the hour. Now I have just started my journey in robotic surgery, and I have seen that there are slight differences in ergonomics that one has to consider: the number of ports, the distance from the target, how we are going to position these ports. So this, I think, is a very important point that one has to start to begin to learn along with our journey in laparoscopy and robotic surgery. So differences in instrumentation, one of the prime barriers to wide adoption of robotic surgery has been cost. So we are here trying to further reduce the cost of operating. Hence, in robotics, we try to reduce the number of instruments. So one can't ask for a hook to dissect and then ask for a scissor and then ask for a robotic Maryland, when in essential you will have to use a robotic scissor to perform all these three functions. Just a small video, since we have done a robotic bilateral TAP being inguinal hernia, and in this we used a left hand bipolar fenestrated grasper and a monopolar scissor for the entire surgery. In addition, for this to suture the flap, we had to use a needle holder. So we don't have the luxury of probably using 3 or 4 or probably 5 instruments, unlike in laparoscopic surgery. Differences in optics. In laparoscopic surgery, we have the luxury of using a 30-degree camera, and your assistant is taught to come onto the lateral or to the right or to the left whenever you're doing dissection. But mostly in robotics, you have a 0-degree camera. There is a slight difference in how you view the anatomy, how you're dissecting, and you have to be aware of the limitations and adapt accordingly. So camera control, this is me assisting my chief, Dr. Prem Kumar Balchandran. So in essentially, when you're operating as a laparoscopic surgeon, you have assigned the camera control to your assistant, and that is not in your purview anymore. But while operating on a robotic system, you have to control in entirety the camera and the instruments. This is definitely an additional mental task, mental load, which you will have to overcome with succeeding cases. So the process is a novice insight to how this happened. I am proud to say I'm an alumnus of World Laparoscopic Hospital. I obtained my fellowship and diploma from Mishra sir in late 2021, and that is probably the early initiation into robotics, where we had a small overview of the Da Vinci system. And of course, now next would be to find a mentor who does robotics. I was blessed to have been with Dr. Prem Kumar Balachandran sir in Greaves Road Apollo in Chennai, and this was the start of my career as a robotic assistant, as a bedside assistant, learning the early ergonomics, the principles of robotic surgery. So in the beginning, I think you'll have to start your journey as a bedside assistant, know the ins and outs of the robo or whatever platform you're using, know how to clear faults, even know how to move the instruments, do the docking, because once you graduate onto a console surgeon, you will have to train your team, you will have to train your assistants individually. So knowing the ins and outs of the robo, not only the surgery, the technical aspects of it is also very essential. So in this entire journey as a novice robotic surgeon, additional technical training has taken up a lot of our time, in addition to learning about how to do these surgeries robotically. Definitely, I think we have a shorter learning curve when we start adopting robotic surgery earlier, and I think this will definitely future-proof our career. So now a lot of studies have come up saying that resident training should also involve robotic surgery, and I think we are at the cusp of this revolution in India, with more and more robotic systems being adopted in large number of institutions, including government institutions. So traditionally this was the route. First you learned open, then you learned lab, then you learned robotic. So currently now open and laparoscopy have an overlap, and then you, as and when you have an opportunity, you move into robotic. But I think in the future, residents, surgeons will be learning open surgery, laparoscopic surgery and robotic surgery in parallel, probably with certain amount of overlap, because there are certain skills which transfer from open to lab to robotic. So we have begun our work with the SSI Mantra 3.0 system, and I bring you welcome from my hospital, Prashant Hospital in Chennai, in Velachery, and I also invite one and all to attend AWR DI Surge in Chennai next month from March 6th to 9th. Thank you so much.
So that was a very good presentation. Actually, I give you my own example. During my residency, I was doing all open cases. My fellowship was laparoscopy, and then under George Fursley, and he's still a very much advocate of laparoscopy surgery. But when I went to the training as an attending surgeon, I learned all robotic. So for the early career surgeon, don't think that you're doing open, it will not be beneficial, but learn the open, then laparoscopy, then robotic. The most important message is that we work in a corporate sector, hospitals, and I came from United States, so nowadays everybody is jumping on the robot, because robot is still the technically easier operation. And so if they're doing like all gallbladders, appendix and everything robotically. So and hospital is very carefully monitoring the finance aspect. So do which is best for the patient's outcome. Don't do just for yourself, because at the end of the day, when they calculate the metrics, they will say that this is a very expensive surgeon, and the other person is not very expensive, and then your revenue generation and your outcome basically will be different. So be careful about that. But it was a very good presentation. Thank you.
Thank you so much. Thank you.